Good afternoon, everyone. My topic is correlation of orbital perfusion biomarkers with clinical activity scoring in thyroid eye disease. As we all know, TED is the most common cause of unilateral and bilateral proptosis in adults, and 90% of the patients of Graves' disease have hyperthyroidism, and 4 to 8% ends in dysthyroid optic neuropathy. Most of these patients follow a Rundle's curve, which has an initial dynamic phase followed by a later static phase. In TED, the orbital inflammation and increased retrobulbar pressure causes alterations in the blood flow of orbital vessels, which further leads to microvascular changes in retina and choroid, which further leads to changes in subfoveal choroidal thickness and retinal capillary plexus blood flow. So the aims and objectives of my study were to study the orbital macrovascular parameters using color Doppler and ocular microvascular parameters using OCT and OCT angio in mild, moderate to severe and sight-threatening TED, and to correlate the orbital macrovascular and microvascular parameters with CAS scoring in TED. It was a cross-sectional study done at Guru Nanak Eye Center in diagnosed TED patients for a period of 1 year, and sample size was 26 patients. Inclusion criteria was age 18 to 65 years. These are the exclusion criteria. The outcome measures were primary outcome, comparison of orbital congestion through superior ophthalmic vein and subfoveal choroidal thickness in TED. Secondary outcome was correlation of orbital perfusion biomarker changes in TED. After written informed consent, a detailed history and complete ophthalmological examination was performed, and patient underwent NCT orbit, color Doppler imaging, and OCT macula and OCT macula by Cirrus HD OCT. These are some of the images from my patient showing the Doppler images of the ophthalmic artery, central retinal artery, posterior ciliary artery, and superior ophthalmic vein, and the central image shows the Barrett's index. This is showing OCT macula showing the subfoveal choroidal thickness, optic nerve head, radial peripapillary capillary perfusion density, OCT macula superficial capillary perfusion density, and superficial capillary plexus vascular density. Statistical analysis was conducted. These are the results. The age of the patient varied from 21 to 65 years, with majority being females. Most of the patients had hyperthyroid, and out of 51 total orbits, 27 had mild stage, and 23 had moderate to severe, and only one was sight-threatening. 29 were inactive TED orbits, while 22 were active TED. Only 3 were active smokers in our study, and the mean intraocular pressure was increased significantly in active TED group as compared to the inactive TED group. The superior ophthalmic, coming to the blood flow parameters, the superior ophthalmic vein maximum velocity in active and inactive TED group was not there was not much difference among the two groups. Same was between the UGOGO staging. Coming to the ophthalmic artery peak systolic velocity, there was in active TED group there was significantly decreased velocity as compared to the control groups, but there was no change in the inactive TED group. In end-diastolic velocity, both the active and inactive TED group had decreased velocity as compared to the control groups, while the resistivity index was also found to be decreased in both the active and inactive TED group, while there was no change in mild and moderate to severe TED. Central retinal artery peak systolic velocity, all the groups had decreased peak systolic velocity, which was significant, and diastolic velocity was also found to be decreased, and resistivity index was also found to be decreased as compared to control groups. Coming to the posterior ciliary artery, peak systolic velocity was also found to be decreased in all the active, inactive, mild TED and moderate to severe TED groups as compared to controls, as well as ED was also found to be decreased. PCA resistivity index was also found to be decreased in active and inactive TED groups, which was significant. Coming to the OCT macula parameters, the ganglion cell complex thickness was not found to be significant among the both active and inactive TED groups. The subfoveal choroidal thickness was also not changed among active and inactive TED group compared to the control group, and among the UGOGO staging there was no significant change. So we test if the congestion in SOV had significant impact on change in SFCT. We found that the model explained only 0.8% of the variance in SFCT was due to the congestion in SOV. The rest we did not know. Coming to the OCT macula, superficially capillary plexus vascular density, we found that active TED patients had decreased OCT macula superficial capillary plexus vascular density as compared to normal groups in the central, parafoveal, superior, nasal, and inferior groups. There was not much change in the mild TED and moderate to severe TED groups. In the OCT macula superficial capillary plexus perfusion density, there was decreased perfusion density in active TD group as compared to the normal groups, which was significant. This table shows that there was no change in mild and moderate to severe TD groups in the OCT macula parameters. The OCTA disc parameters were also not significantly changed. Then we did the principal component analysis for color Doppler, OCT macula, superficial capillary plexus vascular density and perfusion density, and OCTA disc parameters. We found that OCT macula superficial capillary plexus vascular density with a single principal component analysis, 87% of variance was explained with one principal component. So to conclude, no significant change in the superior ophthalmic vein maximum velocity was found between active and inactive TD orbits. There was no significant change in SFCT with the activity and severity of the disease. The Doppler flow velocities in ophthalmic artery are reduced in active TD and mild TD groups. The Doppler blood flow parameters of CRA and posterior ciliary artery are reduced in both active and inactive TD groups. There is decrease in value of OCTA, superficial capillary plexus vascular density and perfusion density in active TD groups as compared to normal controls. And after doing the principal component analysis, we concluded that in a patient of TD, OCTA macula, superficial capillary plexus vascular density is a quick and cost-effective investigation which one could advise in place of orbital color Doppler imaging for follow-up. The small sample size of the study reduced the external validity of the findings of this study. Thank you.
The Doppler study.
Yes. Sorry, sir.
Disadvantages of Doppler study.
So it was observer-based study.
One. Second.
And if we'll press more on the globe, then the velocity will be found to be reduced. And the position of the patient head was also, he was partially forward, forehead position.
That's a big problem with this study. So what is the ideal study for to know the vascular perfusion?
Which place?
In thyroid eye disease.
Ideal, so we usually do color Doppler only.
You are telling yes, correlation orbital perfusion biomarkers. Is it only the Doppler or any other study, any other investigative tool you can use it? If you use MRA angiography.
So, those are but invasive, so that's why we don't use invasive for a TD patients. We have to inject the drugs and then we have to do the angiography. So we go for a Doppler which is non-invasive, and then we have OCTA macula angiography, which is also non-invasive and is a faster. So that's why.
Yes. So Doppler is one of the disadvantages. That is operator dependent. And that depends on the patient also.
So what advantage you have? You are suggesting that we should do OCTA, no?
Yes, ma'am.
So what advantage what information we will gather, and how can we help the patient in these?
Ma'am, actually we could not find a cutoff value for the parameters. This is the cutoff value for active TD and this is the cutoff value for inactive TD. We have to involve much more patient sample size to come to a conclusion. See, this is a value. If the patient has average value less than this, so he's in active TD group, and if his value more than this, then he's in inactive TD group. And along with it, we have to see CAS scoring also.
Yeah, so we can define with the CAS score also. So what advantage of OCTA in this?
Ma'am, but CAS scoring is also subjective and objective also, because the patient may complain of he has pain, he has no pain, so then he may go in more than 3 out of 7. Some patients simply don't consider pain as a symptom.
Okay.
So.
Okay. Thank you.
Thank you.